Hey, what's up, guys? What's up, Ninja Nerds? Hope you guys are all doing well. It's been a bit since we've done a case study. Um, Very excited to be able to get back with you guys and get started on this stuff. So we're going to be doing this a little bit differently. So what we were doing prior with the case studies is we were doing kind of like a chief complaint, dissecting it and trying to come up with a diagnosis and talk about treatment and so on and so forth, right? What the goal I really want to try to accomplish now is I want to try to make these case studies a little bit more focused on really taking it to the next level, using evidence-based medicine. And whenever we're looking at a particular disease like atrial fibrillation or whatever the next one is, I want us to be able to know how we should actually truly, in a clinical setting, whether that be in the ED, whether that be in the ICU, whether that be on a internal medicine floor, when we're managing these patients who are critically ill with AFib, how do we actually approach it? How do we evidence-based wise treat them, etc.? So that's kind of the goal of these new styles, is that we're going to take a disease and look at it as how to diagnose it, treat it, and be very efficient in a evidence-based approach. So that's my goal here, okay? Tell me what you guys think. If you guys don't like it this way, we can always try to do something a little bit different. But I really think this is going to be a cool way of trying to do these, okay? All right. So first things first, all the stuff that we talk about in these cases that we're doing, they're primarily just for educational purposes. If we do mention any kind of cases or any kind of individual or patient that we're analyzing in this scenario, it's not real. We've just made them up, and if it's brought up in this scenario. So I have kind of a question for you guys out there is, when we talk about atrial fibrillation, there's kind of two scenarios behind someone with atrial fibrillation. So imagine someone came into the emergency department, they had no prior medical history, and all of a sudden they just pop into an AFib. But they're there because they have pneumonia, or they're there because they have some type of septic process, or their COPD is acting up, or whatever. There's some underlying disease, but they never had a history of atrial fibrillation. What is that called whenever someone never had a prior history or documentation of atrial fibrillation, but maybe some type of critical illness caused them to pop into AFib all of a sudden? What is that called? Any of you guys know? Pop that down in the comment section if you guys do know. It's a pretty simple kind of option here. These are the ones that I really want us to focus on because they're usually the sicker ones. We kind of use the term NOF, new onset atrial fibrillation. So new onset atrial fibrillation is usually when someone had no previous documentation, history, chart review that showed any history of atrial fibrillation that was chronic in nature. And they had just some type of infectious process or some type of COPD or something that's causing it triggering them to go into this new onset atrial fibrillation. So that's one type. And then the second type is someone who has a history of chronic AFib, and all of a sudden from their critical illness, they develop potential worsening of their atrial fibrillation. So those are the two common scenarios that I wanted to bring about. So it's usually someone with a chronic AFib who has potentially worsening AFib because of an underlying critical illness, whatever brings them to the hospital, or they have a new onset AFib, which is secondary to their critical illness. So those are two different types of scenarios that I want you guys to think about for atrial fibrillation is, again, a chronic AFib with a critical illness that's worsening their already present AFib, or a new onset atrial fibrillation with developing secondary to some underlying critical illness. And we'll talk about those ones. This is the one that I really want us to focus on, okay? Because usually those chronic AFibers, those are the ones that are a little bit easier to manage sometimes, okay? All right, cool. So that's what I kind of wanted to talk about. But either way, in these patients, someone who has kind of a new onset atrial fibrillation, or they have a chronic AFib and they have some type of critical illness which is making their chronic AFib worse, usually the underlying pathophysiology behind that is pretty much very straightforward. There's not a lot of actual data out there in evidence that shows how we should manage patients with atrial fibrillation who are critically ill. We have those studies that show us, how we actually should manage them in outpatient settings. But when a person's critically ill, they develop these catecholamine surges, right? So whatever the trigger is, whether it's an infectious process, whether it's some type of medication, whether it's a bleed in the brain, whatever it is, that trigger causes this increased catecholamine surge. Lots of norepinephrine, lots of epinephrine get released into the circulation, and that triggers these higher tachycardia types of manifestations in the form of atrial fibrillation. And one of the things that we do know about these patients with critically ill situations with these onset AFibs that are new or chronic AFib is that they respond better to beta blockers. And so we'll come back to that a little bit later, okay? But these are the two scenarios that I want you guys to be thinking about. All right, cool deal. Oh, shoot, hit a bunch of buttons. Okay, so let's go here to the next thing. So whenever someone has new onset atrial fibrillation, I want you guys to go ahead and tell me something. Okay, let's kind of go through step by step. Someone develops new onset atrial fibrillation. You walk into the room, they're here for another issue, but you walk into the room, you're looking at the monitor, and you see this new irregular rhythm. You see them being tachycardic, greater than 100 beats per minute, and it looks like atrial fibrillation. You print off a 12 lead EKG and it confirms atrial fibrillation. What could be some particular electrolyte causes? So whenever we think about a person popping into AFib, we want to have a particular approach. And so thinking about the causes, it makes it easier to figure out what kind of tests we're going to order. So what electrolytes, two electrolytes that I want you guys to tell me, if these electrolytes are altered in some way, it can put a person into new onset AFib or worse than their already present chronic AFib. What are those two electrolytes? Can you guys tell me? And also tell me if it's low or if it's high for those two electrolytes. So I want to know the two electrolytes, and I want to know if they're high or if they're low. Because these are quick, easy. These are two of the electrolytes that we could easily just order a lab for and say, hey, oh, there you go. This ion is low or high. If we replace or remove it, this potentially could help. So Nagar said potassium. And a lot of you guys said potassium. Boom, I agree with that. Hypokalemia is definitely one. That's probably a big one. So checking to see if there's a low K. And then Mr. Smoker, I like it. And Bander said hypomagnesemia. Yep, those are the two ones that are most commonly associated with someone having a new onset AFib or popping into AFib, is someone having a very severely low magnesium or a very low potassium. So that's a quick, easy thing to think about. Okay, so that's one. You guys are on the ball. The second thing is, let's go to this catecholamine surge. Anything that can increase your catecholamine kind of drive would definitely be something that could put you into AFib. So what is ways that we could increase your actual beta adrenergic drive? So we're giving specific maybe medications, or there's certain toxins that you're taking or drugs that you're taking that are not actually medication prescribed, that increases your sympathetic surge, and that increased epinephrine, norepinephrine works on the heart and increases your heart rate. So again, tell me a couple different drugs / medications that can increase your sympathetic drive. One of them is very easy. I mean, think about beta agonists, beta 1 agonists. What are some drugs that increase the activity of the beta 1 receptors? If any of you guys know, throw that down there. So some of you guys are saying hyperthyroidism. That definitely increases your sympathetic drive. Yep, I agree. Pulmonary embolisms, they increase your sympathetic drive. It also could be the hypoxemia that causes that as well, but yes. Oh man, you guys are great. So Ramea, you hit a real like white whale, but that's a pretty interesting one. Pheochromocytoma, definitely. That's definitely a possibility. Albuterol, good. And vasopressors, inotropes. What type of vasopressors? And then Nagar said isoprenaline. So isoproterenol, definitely one. That's possible, yep. And then dobutamine is one. Albuterol is one. Epinephrine and norepinephrine would also be one. So yeah, you guys are hitting it right on the head. So I think you guys hit a pretty good amount of ones. So beta 1 agonist. So and any kind of beta agonist, technically even beta 2, like your albuterol, that technically can act on beta 1 receptors and kind of increase your heart rate. So yeah, you guys hit it on the head. So I'd say epinephrine, norepinephrine, dobutamine, isoproterenol. Those are good ones. Albuterol. And then Jet D just said it, cocaine. Yep, cocaine, methamphetamines, things of that nature. Mohammed said cocaine. So those are great. Yep, I love it. So you guys definitely hit the nail on the head for those. I would definitely agree with someone saying low mag, low potassium, and then anything that increases your beta adrenergic drive. So dopamine to a small degree, isoproterenol, norepinephrine, epinephrine, albuterol, and cocaine, methamphetamines, as well as things that such as thyrotoxicosis definitely can do that, and pheochromocytoma. So yeah, you guys are on the ball. I love it. Okay, so we hit some of those. Okay, whoops, I don't want to hit just yet. Okay. So the next thing that I want you guys to think about is, it's a little interesting, but sometimes not just the medications, but if we think about other particular triggers. So we hit electrolytes, we hit sympathetic drive. The next one is hypoxemia. So hypoxemia, low oxygen levels, can definitely push a person into an atrial fibrillation because it agitates those atria. They need the oxygen to be able to power, to generate ATP to power those pumps. And so because of that, if it doesn't work, they start to go into these kinds of own generated rhythms. So what are some conditions that can worsen your actual can cause hypoxemia, lower your oxygen concentration, and push someone into AFib? Just a couple. Anything that you can think about that are super pertinent and actually like relevant to putting someone into severe hypoxemia. So what are a couple things, just very common disorders to think about? Don't hit me with any like, zebras, just some pretty common things to think about here. So again, anything that can really trigger a hypoxemic state. Someone said it prior was pulmonary embolism. So that would definitely be one. I would throw that one right on the top. That could definitely push someone into AFib. Emphysema, yeah. So any kind of COPD exacerbation can definitely do that. Pneumonia, yep. Nagar with the cyanide poisoning. I love it. Yeah, so I would go with pneumonia, COPD, pulmonary embolisms, even pneumothorax definitely is a possible one as well. But yeah, I like it. So those are big things to think about. And then the other thing to think about is, so we've gotten down, I kind of like to think about electrolytes, high sympathetic surge, hypoxemia, or ischemia. So then I go to the next thing, which is kind of your ischemic states. And so you guys have already kind of been hitting that in and out throughout this whole process, but any kind of ischemia to the myocardium can cause significant change in permeability of the atria and the ventricles, and then ions can just flood into those and cause someone to pop into AFib or some type of fatal arrhythmia like VTAC, VFib. So I like it. So you guys have hit some good amounts of ones, good answers here. There's one last one that I actually like you guys to think about that is really interesting. Robic said a really good one. I like that. Holiday heart syndrome. That's definitely like a USMLE or PANTS kind of answer there. Definitely, someone goes heavy drinking, binging, drinking tons of alcohol. That can definitely push someone into a nuance at AFib. Absolutely good answer there, Robic. One more that I like to think about that I kind of see interestingly in the ICU is we do a lot of central lines or swans, so right heart caths. And when you put that catheter in and you thread your guide wire down, you put your triple lumen over that and thread that down into where you're hopefully getting to like the superior vena cava, right atrial junction is where you like the tip of the catheter to be. Sometimes if you hilt the catheter a little bit farther down and it gets into the atria, sometimes that can just tickle the atria a little bit and agitate it enough that it could pop someone into AFib. But that's something to think about kind of as a diagnosis of exclusion, that you've kind of ruled everything else out. Take a look at that chest x-ray. Where's the tip of that catheter? Is it in the right atrium? And that's why. So that's another one to be thinking about. But these are things that I want you to think about as if someone is in the hospital and they're critically ill. What are some things that I can quickly run through to think about why this person is popping into new onset atrial fibrillation with their critical illness? Okay? So let's look at some of those and see if there's anything else that we kind of missed up on here. So if we go through here, we hit electrolytes, which you guys are beast moding about. We hit the tox medications, right? So beta-1 agonists. So this is an interesting one. I've actually noticed this a lot being in the ICU lately, is that a lot of people get tons and tons of fluid in the ICU. And when you get so much fluid, it actually distends those atria a lot. It puts you in kind of a fluid overload state, and it dilates those ventricles, it dilates those atria. And stretching those atria past their normal capacity can just agitate them enough to put someone into atrial fibrillation. So believe it or not, someone being very fluid overloaded with prior heart failure and kind of putting them into this high hypervolemic overload state can actually put someone into AFib. So be careful giving fluids. And then we hit the catheter related. We hit some of the high catecholamine related states. You hit thyrotoxicosis. Obviously, anybody who's septic is going to put them into these high heart rate states because their blood pressure drops and your heart rate has to go up to try to be able to maintain a good cardiac output. And this is another good one. This is the one I see a lot in my ICU, is patients who are coming in who have alcohol abusers, use benzos, use opioids, and then they go a couple days without any of those things, and they go into withdrawal, and they start getting super tachycardic, hypertensive, they start tremoring, they start having a lot of withdrawal symptoms. So think about withdrawal as well. And then the last one here is another one that I see a lot of, is bleeds in the neuro ICU. So whenever someone gets into this, they develop a brain bleed, their actual central nervous system goes into this like sympathetic fight or flight mode. And what it does is it actually tries to increase your heart rate and increase your blood pressure to perfuse the brain. Because whenever you have injury to the brain, sometimes those ICPs go up. You want to make sure that you perfuse it as well as good as you can. So you try to increase your cerebral perfusion by increasing your MAP, and increasing your heart rate is one way to increase your MAP. So those are things to think about. So these are all those causes that I wanted you guys to think about here, because it's going to help us. We can figure out how to diagnose these and figure out what could be putting this person into this new onset AFib. All right, cool. So this is a pretty easy thing to think about here, right? So we have a patient that we look at the monitor, and when you're looking at the monitor, you're like, dang, that looks like it's irregular. Don't ever just say, oh, it's AFib. Okay, no. Sometimes things can look irregular and it's not actually, it's not actually AFib. So what I would suggest to you guys to do is whenever you think that someone is having an irregular rhythm, they're getting tachycardic, I would just print off a 12-lead EKG, okay? So get a 12-lead EKG. When you get a 12-lead EKG, whenever you're reading these, you should read them every single time the same exact way so you don't miss anything. You always determine rate. Then you determine rhythm. Then after that, you determine if there's any sinus P waves, and is there a P wave followed by the QRST. So Gabriel Alendi asked a question. He said, but sepsis, question mark. I'm not sure what you mean, buddy. So yeah, sepsis can definitely put a person into AFib just because it... Again, whenever you have a drop in your blood pressure, what happens is your renin-angiotensin-aldosterone system gets activated, as well as your sympathetic nervous system gets activated, because you're trying to be able to maintain an adequate blood pressure and perfuse those organs. And so whenever your sympathetic nervous system gets activated, it causes an increase in heart rate, an increase in contractility, an increase in vasomotor tone, anything that we can do to increase the blood pressure. So sepsis is definitely a very strong trigger for someone going into a new onset AFib or worsening their present AFib with a critical illness. So yeah, I would check and make sure, look at the EKG, go through the rate. If you're looking at the rate and it's greater than 100 beats per minute, that's something to think about. Okay, we're tachycardic. And then I look at the rhythm. Is it irregular? Okay, if it's irregular, it could be AFib. What do I need to know? Are my QRS complexes narrow? If they're narrow, it's irregular, and it's going fast, then this could be what? A person who has AFib, that is with a rapid ventricular rate. Then I look to see, is there any sinus P waves? Look at lead 2 and look at V1. If you see in lead 2 and in V1, there is no, so someone said, Enrique, isn't sepsis a catecholaminergic state initially due to the EBB and flow theorem? I'm not quite sure what that means, buddy. Yeah, if you could explain what that means, the EBB and flow. I'm not quite sure what that means. I'm sorry. But yeah, in generally, whenever someone is in a septic state, it's definitely going to produce a catecholaminergic surge. That's a pretty common thing. That's why they usually become tachycardic. They try to, clamp down on their vessels, but if their vessels are so like refractory in such a refractory vasodilatory shock type of manner, they're not going to be able to increase their vasomotor tone. and they also increase their cardiac output. So that's why sometimes in these patients who are septic, you can see that if you do an echo over their heart is just clanging and a banging because they're trying to increase their cardiac output, and their heart rate is increasing because they're trying to increase their cardiac output to increase their blood pressure. So generally in a septic state, it causes these patients to go into a catecholaminergic state. But anyway, let's get back to this. So we have a patient, 12 lead EKG. We go through it. We're looking rate. And again, if you're worried about atrial fibrillation, if they're like less than 100, you can still have atrial fibrillation, but those ones aren't the ones that are concerning. Someone who is actually like popping into, I get nervous whenever I see a patient hopping over 150 and sustaining over 150. Anything like, 100, 110, I'm not super concerned in a critically ill patient because that may actually be a compensatory mechanism that they're actually utilizing if they're septic, if they're having some type of underlying critical illness that they're using to maintain their blood pressure. So me actually trying to fix that could actually make them worse. So again, look at their rate, look at their rhythm. If it's fast, irregular, narrow QRS complexes, no P waves in lead 2, and in V1, those are the main ones that I look at, I would consider this being an atrial fibrillation. Now, what would make me poop a brick is if I see a heart rate greater than 200 beats per minute, I see a fast rate, I see an irregular rhythm, and I see wide QRS complexes with varying morphology and no P waves in lead a V1 or lead 2. If I see that, my sphincter is puckering and I'm going to be really nervous because then I'm concerned about someone having what's called a AFib with a pre-excitation syndrome, like Wolff-Parkinson's-White syndrome. So those ones are a little bit more concerning. But nonetheless, that's the first thing you should always order is a 12-lead EKG and confirm that it is in actual atrial fibrillation. If you put someone on anticoagulation because you never checked a 12-lead EKG because you think they have AFib, you're putting them at risk of a bleed. So make sure you confirm. Oh, thank you guys for so much. I appreciate everything you guys do. Thank you, Peterus. All right. So boom shakalaka, we covered that part. The next thing I really think you should always do is never blindly order troponins. I get so frustrated with this because whenever someone's getting admitted into the hospital and they have this, nuanced AFib, we check an EKG, we look for any signs of ischemia. If you see ST segment depression, if you see ST segment elevation, if they're complaining of severe chest pain, if they have a cardiac history that really concerns you for them having ischemia, their blood pressure is really low, there's real concerning signs, then get troponins. But do not just order a troponin if their EKG shows no signs of ischemia, they do not have any chest pain, and they don't really have any cardiac risk factors. In those situations, please, for the love of goodness, do not order a troponin because they may come back elevated, and that doesn't mean anything. It just means that they may be in a demand ischemia state, that they're trying to increase their actual cardiac contractility, so they have a higher demand to be able to meet that actual higher cardiac contractility. But it doesn't mean that they're actually having an infarct. So please don't order that unless you have a concern. So get the 12-lead EKG, only add the troponins on if you're worried about ischemia, and that'll help to rule out that MI cause. Quickly order a BMP. That's a very easy test, and add on a magnesium. Why would the BMP be good? It can show if my potassium is low, and it can show if my magnesium is low. Okay? Review their medication list. Are they on albuterol? Are they on an epi drip? Are they on a norepinephrine drip? Are they on some type? Do they have a history of cocaine, methamphetamine use? Are they taking dobutamine? Are they taking isoproterenol? Okay? The next thing I would say is after you've gone through that and you've looked at their medication list, okay, then let's say, okay, do they have any other issues here that could potentially be concerning? So do they have an alcohol use history? Do they have a benzo or opioid history? When's the last time they had one of those things? Because if it's been a while, they could be in withdrawal. Are they in pain? Are they anxious? Once you've gone through those things and you try to review all their medications, you can remove whatever one you think could be triggering this. So good question, Sean. A BMP stands for a basic metabolic panel. So it's kind of like a chemistry panel that tells us our sodium, our potassium, our chloride, our bicarbonate. It tells us our creatinine, our BUN, and it also tells us our fasting glucose, or in this case, it could be just a random glucose. Depends upon if they're eating or not, but it just gives you a blood glucose levels. Okay? So these are the things I would look for, okay? 12 EKG, confirm it's AFib, troponin if they have ischemia and you're concerned about an MI, BNP to look for low potassium, low magnesium, review the medications to look for any type of beta agonist, look at their medical history to see if they have any history of alcohol or drug abuse, and then again, chest x-ray. Why? Why would we get a chest x-ray? What would that tell me? What could a chest x-ray tell me, Ninja Nerds? Yeah, pneumothorax would definitely be one. What else? If I see a big old fat infiltrate, big old fat opacity in like a lung portion, it could tell me that, oh my gosh, they have pneumonia, right? So that could be one thing. Look at their history. Look, do they have any history of COPD? Are they wheezing? Do they sound short of breath? Are they complaining of shortness of breath? Does their lungs have that characteristic look of a COPD? So I would say definitely look to see if they have a pneumothorax. I'm definitely good with that. But also look to see if they have any pneumonia. Look to see if their lungs look COPD-ish. And if they have a history of COPD, maybe they're just having a worsening or exacerbation of their COPD. Now, would a chest x-ray show a PE? That's my question for you, engineers. Would it show a PE? Yeah, it also could show cardiomegaly. That's a good thing too. So it could show cardiomegaly. Good point. I like that. Could a chest x-ray tell me if I have a PE though? No. Yeah. It's actually one of the most common findings is a normal chest x-ray, right? So someone who's hypoxemic or they're tachycardic or they're short of breath or they're dyspneic or whatever it may be, there's no usual obvious findings. There is things like a Westermarck sign or a Hampton's hump. Those are so rare, and they're non-specific. Like their sensitivity for determining if someone has a PE is very low. So determining like a Westermarck sign or a Hampton's hump is not a great thing to go off of. Okay. Yeah, Bander said that Westermarck or Hampton's hump. It can be. It's one of those things that you learn in the textbooks, but it's pretty much. It's one of those things that it's really not a sensitive and it's not evidence based that we should depend upon that. I would really go off of saying, hey, let's take a look at their echo and let's take a look and see if their pretest probability, like their Wells criteria, warrants them to have a concern for a PE, and then for them to consider sending them to get like a CTPA. But a chest X-ray would not give me the definitive evidence of a PE. So I would get a chest x-ray. That would tell me, again, is there any pneumo? Is there any pulmonary edema? That's also another thing. Is there any significant pulmonary edema? As well as, is there any cardiomegaly? But big thing is there any kind of pneumonia as well? COPD exacerbation. Okay? So once we've done that, what else could a chest x-ray tell me? If someone's in the hospital, they've been in there, they had to get a central line placed, and you put a central line in, and you see, oh, shoot, that catheter's dangling down in the atria. Maybe pull that catheter back a little bit. So that's another thing to consider as well. Okay. Dane Shaw said, does a PE mean pulmonary embolism in that case? Yeah, sorry. PE is a consideration of a pulmonary embolism. Enrique said EKG is better for PE. It could be, yeah. I don't disagree with that. I think it could show potentially any signs of right heart strain, and that's where an echo could come on nice as well, as long as you had a previous echo to compare to. So sometimes if people, one of the problems is that if we say, oh shoot, slap the echo over their heart, and we say, oh, that right ventricle looks dilated, it's not moving very well, it's dysfunctional. Their ventricles look a little bit, their right ventricle looks bigger than the left ventricle. What if they had a history of COPD? What if they have a history of pulmonary hypertension? What if the right ventricle already has been like that? And then you think, oh, shoot, that right ventricle is, that thing's dilated. They got right heart strain. Same thing with their EKG. If you get an EKG and you look at it and you say it shows right heart strain, make sure they look at previous EKGs to show that the right heart strain wasn't there previously. So it's, again, looking back at their medical history, looking back at previous tests, because if they had a previous right heart strain, that's not reliable. If it is an acute change and they had that before, that's something to be concerned about. So yeah, EKG I agree with. The S1Q3T3 is a good test for your exams, but it's not truly like as sensitive and specific as you would think in a true clinical setting. It's rare that we see that. Usually the more common finding is someone to be tachycardic and potentially having signs of right heart strain. But I would slap over the echo over that right heart, compare it with the previous echo that they had listed, and see was there any difference in that. So that's a big thing. But also look at their pretest probability. So you have to go through their Wells criteria, right? Determining, okay, if off their Wells criteria they have a high pretest probability, well, do I send a D-dimer and then consider them getting a CTPA, or do I send them to get a CTPA right away? Okay? Nonetheless, though, those are pretty quick things. So we got our 12 EKG, tells us if it's AFib. Troponins look if there's ischemia. You can consider some right heart strain at 12 EKG. And then the next thing is BMP. Again, look for low potassium, add the magnesium for low mag, review their medications, look at their chest x-ray. Echo is a really good one because it just looks at, again, if there's any wall motion abnormalities that could be indicative of an MI, and it also could be indicative of any kind of right heart strain, which could be potentially seen in a PE. So that's another thing to think about. And then urine tox screen. So with that urine tox screen, that's good because that can rule out any kind of cocaine, methamphetamines. If they drink alcohol and they've been using alcohol, if they have been taking benzos, if they've been taking any types of opioids as well, because then that could determine if they were using any particular toxic medications, and we have an idea of what they were utilizing previous. But just make sure that whenever you check that on their en route, whenever they were coming to the ED, or when they were in the ED, they didn't get any kind of benzo, they didn't get any kind of fentanyl, so that just make sure you keep track. Okay, they got this medication in the ED. They got this medication in the EMS, and that's why their tox is positive for this. So make sure that you follow through with that. And the last thing is you can always order a TSH with reflex, right? I'm not opposed to this. I think it's a great thing to think about because, again, this can pop someone into a new onset AFib by that high catecholamine surge. Okay. So I'm just quickly looking at you guys' comments before I move on to the next thing here. I think vascular markings is not specific. I think so. I had a patient that came in with ARDS on an AFib with a heart rate 179 that went into asystole, then a brady of 42. After that loading dose of cortisone, is it normal? I had a patient that came in with ARDS on AFib with RVR that went into... Yeah, it's interesting. I don't know what to make of that, Elisha. I don't know if all they got was the cortisone. Hopefully they didn't get a kind of overweight controlled. Sometimes I think and we'll talk about that a little bit later here, but treating patients with AFib, targeting a heart rate, sometimes we push the heart rate down too much and it actually can cause them to become, and sometimes they have tachybrady syndromes as well. I'm not quite sure about this. Without having all of the medical history about this patient, it's tough to say. Okay. All right, so let's keep popping through. I think we'll answer some of these questions as we keep going through. But I think this is a good way of kind of like running through. Like this is my quick like little approach to how if I have a patient that comes into my ICU and they have a new onset AFib or they have atrial fibrillation and it's getting worse or whatever, particularly more new onset AFib, I run through these tests. Okay. Now that we've done that. Next thing, my question to you is, if we're going to emergently cardiovert somebody, there has to be a particular reason. So I am not, to be honest with you, I think since I've been, I don't think I've ever cardioverted somebody in the ED. They do a lot, but usually in the ICU, it's uncommon for me to be able to cardiovert somebody. So here's the question that you have to ask: if someone is coming into your ED, your hospital, your ICU, whatever it is, and they're hemodynamically unstable, because that's one of the common reasons that you would actually cardioverт somebody, right? Is you're trying to cardioverт somebody who's hypotensive, they have severe alteration in their, they have a flash pulmonary edema, they have an altered mental status, so on and so forth. So my question for you is the AFib driving the hemodynamic instability, or is the underlying process, the causes that we talked about, driving their hemodynamic instability, and the AFib is just a byproduct or compensatory response to that? So that is something that's very, very important to think about, okay? So again, AFib, cause of hemodynamic instability, that is a very important thing to think about. Or is the underlying disease causing the instability and the AFib a side effect of their compensatory response? That's why when someone comes in to the ICU and their heart rate's less than 150, you got to remember what cardiac output is equal to, right? It's equal to the heart rate times the stroke volume. So if your heart rate's going up, right, it's going to increase your cardiac output. However, if the heart rate stays sustained greater than 150 for a long period of time, that alters your diastolic filling process, right? Decreased diastolic filling can potentially lead to a drop in the stroke volume. So that is a big thing to think about here. So whenever you're going through this process, it is important to remember that, again, if the heart rate is less than 150 and it's not sustaining greater than 150, it is very unlikely that it is the cause of the person's hemodynamic stability. And therefore, shocking them is not going to make a difference. It's not going to help. Okay? If their heart rate is way greater than 150 and it's sustaining, and they have structurally abnormal hearts, they have issues with, they got a mitral stenosis and aortic stenosis, they have pulmonary hypertension with right heart strain. Those are particular concerns why I would say, okay, this is unlikely to be the bystander, and definitely AFib could be driving their instability, because in conditions like pulmonary hypertension, mitral stenosis, aortic stenosis, diastolic dysfunction, these conditions are dependent upon that atrial kick. And in AFib, you lose that atrial kick. So if a patient has these types of underlying diseases and they're in a rapid AFib, they're losing their atrial kick, and that can definitely drop their cardiac output and drop their blood pressure. So my thing is, unless the patient has these particular structural abnormalities and their heart rate is popping up above 150 to sustained, I don't think that cardioversion is going to help them. And also, if they have an underlying illness, guess what? You can cardiovert them and they can revert back to normal sinus rhythm. But because their underlying cause isn't treated or reversed, they'll quickly pop back into AFib. So I really don't find much benefit, in the literature also kind of shows this to some degree, that putting someone through the direct current cardioversion, shocking them and getting them out of their AFib and putting them into normal sinus rhythm, it may work, but if you don't fix the underlying cause of why they're in AFib, they're just going to revert back to AFib. And the only times I would consider potentially putting someone through the whole process of cardioverting them is if they have these underlying disorders, and on top of that, their heart rate is sustaining over 150, because then they lose their atrial kick, and definitely it's driving their hemodynamic instability. Cardiovert them. Okay? Even if they pop back into it, I think it's worthy of cardioverting them. The one situation I would do immediately without a shadow of a doubt is if a person came in, their heart rate's popping above 200, they got a wide, irregular tachycardia showing AFib with WPW, I'm shocking them like it's going out of style. Okay? These are the scenarios in which I think cardioversion would be a benefit. Is if a patient has AFib with WPW, you shock it. Or if they have a hemodynamic instability, which is likely what? Heart rate sustaining above 150, these types of underlying structural heart diseases which are dependent upon the atrial kick, you should shock them. Okay? If they're a chronic AFibber, please do not shock them, because it's likely a bystander and it's probably not going to work very well. And you can probably shock them, and they may not go back into normal sinus because they may have a permanent AFib. And so doing this wouldn't provide any benefit. Okay? So I hope that answers a question as to when someone's in the ICU. For me, I rarely ever shock somebody, just because if they're critically ill, I can shock them, get them in a normal sinus, but they probably revert back. And again, oftentimes it's very unlikely that AFib is the cause of someone's hemodynamic instability. But if they have these and they're also hemodynamically unstable and they're in AFib, popping above 150 sustained, I can make an argument that they could be causing their hemodynamic instability and they warrant cardioversion. Okay? I hope that answers some questions. Okay. So I'm going to take you through I'm sorry. Someone said WPW, Wolff-Parkinson's White syndrome. I apologize. I missed that. Okay. So I'm going to take you through how I treat atrial fibrillation, right? Now here's the thing. Someone comes into the ED, they're in rapid AFib down there, but they have some underlying illness, right? They had a stroke, they had a bleed, and they're in a rapid AFib. As long as their heart rate isn't popping above 150 sustained, they're not hypotensive, they have no abnormally structural heart disease, and they don't have WPW with their AFib, I'm not shocking them. What I will do is I'll determine, is there anything else that could be driving their AFib? Because if I fix that, I may be able to get them out of that AFib into normal sinus rhythm, or at least like worsen the situation of their AFib. So I go through ABCs all the time: airway, breathing, circulation. First things first, airway. Do we need to secure their airway? Are they having difficulty breathing? Are they tachypnic? Are they exerting increasing work of breathing? They're utilizing scalene muscles. They're nasal flaring. They're belly breathing. Any of those signs that could potentially concern me for, okay, this could be some type of hypoxemia related push into AFib. The next thing is circulation. Are they hypotensive? Because if they're hypotensive from their underlying sepsis or cardiogenic shock or whatever it may be pushing them into a AFib. So increase their blood pressure, optimize their hemodynamics. Then, quick, easy things that I also look for. Treat their pain. Are they in pain? If they are, I'll give them a little bit of pain medication. Are they anxious? I'll give them a little bit of anxiety medication. Also, look for any obvious signs of what else? Look for any particular concerning electrolyte disorder. So right away, I'll check their mag. I'll check their potassium. But you know what? Sometimes it takes a while for that BMP to come back. I don't always give potassium right away. That's something I wouldn't do. But I will give a 2-gram mag writer or a 4-gram mag writer to the patient, regardless of what their mag level is, if I don't know it, because it's not going to likely cause any harm, and that's probably going to get cleared out. As long as they have good kidneys and they have no underlying like severe chronic kidney disease or severe AKI, it's unlikely that giving them a 2 or 4-gram mag writer is going to hurt them. So I'll give them 2 or 4 grams of magnesium right away. Check their BMP. Once their potassium comes back, I'll replete their potassium as needed. Okay? So once I've done a lot of those things, that kind of helps me. So here, I'm going to take you through my whole step-by-step process. Ready? So here's what I do. Anytime they come into my ICU, I say, okay, let's look at their airway. Are they having any difficulty breathing? Do they have hypoxemia? So I look at their monitor. Is their O2 sats low? Are they working hard to breathe? Are they not really breathing very much at all because they have a severe bleed or they have something else that's going on that's causing them to become hypercapnic and really somnolent? And those things, maybe I'll order an ABG to see what their true oxygen status is, or a VBG if I want to look at their CO2, okay? Once I've done that, I'll say, okay, are they hypoxemic? Put them on a high-flow nasal cannula. Are they having a COPD exacerbation? Put them on BiPAP. So if they have any issues where their oxygenation is a problem, OptiFlow or high-flow nasal cannula is great. And if they have issues with CO2 retention, BiPAP is great. If they have cardiogenic pulmonary edema, BiPAP is great. So these are the situations which I do right away, because if I fix these, it may help them. Okay? The next thing is circulation. Like we said, they're hypotensive. Get that blood pressure up, right? Support those hemodynamics. But be careful, right? So what were the things I told you right away? Look at their actual medication list. If we look at their medication list and we see that they're not hypotensive, they're actually kind of, their blood pressure's up a little bit and they're super tacky and they're on any of these medications, what could I do? Discontinue them. Stop giving them these. This could be driving it. Okay, so I'll DC these. Then, someone said, what is an ABG and a VBG? Great question, Yasser. An ABG is an arterial blood gas, so it tells me the person's arterial pH, arterial oxygen, arterial CO2, and arterial bicarbonate. A VBG is a venous blood gas, so it'll tell me their venous pH, their venous O2, their venous CO2, and their venous bicarb. I like VBGs for primarily looking for CO2. I like ABGs for primarily looking at O2. It depends. If I have an arterial line, I like to get ABGs. If I don't have an arterial line and the patient's wide awake, I don't want to have to stick them in their artery. And if they're not hypoxic and I'm not concerned about that, I will get a VBG to just look at their CO2. Okay? Great question though. So again, circulation, is their blood pressure low? If it is, I'm going to throw them on a little medication to maybe increase their blood pressure. So I'll consider something like phenylephrine or vasopressin. Now, most people will be like, what the frick? You're going to put someone on phenylephrine or vaso? What if they have like some type of like heart failure or their left ventricular ejection fraction is bad? There's actually been literature that's shown that phenylephrine or vasopressin, even though they clamp down on the vessels and increase your afterload, increasing your blood pressure, it also causes the veins to constrict, which increases your preload, which increases cardiac output. So there seems to be this way of it kind of evening out. And unless you're pushing like large boluses of phenylephrine or, which you don't really push boluses of vaso, but if you're pushing large boluses of phenylephrine, that could potentially drop your cardiac output. But There's research that shows that phenylephrine is pretty good, and it also creates what's called a reflex bradycardia. It's not significant, but it might drop your heart rate down about 10, 15 beats per minute, but it's primarily fixing the underlying issue. They're hypotensive. If they're hypotensive, that might be driving their reflex tachycardia, putting them into this new onset AFib. Okay, so which is more superior, BiPAP or CPAP class act? I prefer BiPAP. BiPAP is great for cardiogenic pulmonary edema. CPAP is a little bit tough because it's a constant pressure. So if you're setting a person at 15 centimeters of water, they're getting that during the inspiratory and expiratory phase. If you're putting someone on BiPAP, you're putting them on a certain pressure during their inspiratory phase and during their expiratory phase, okay? And you're giving them a little bit of that PEEP with the expiratory phase. So with BiPAP, I prefer that because it's going to give you an inspiratory pressure. I usually start with like 15, an IPAP of 15. And then I start with an EPAP of somewhere around 5, and then I titrate up on that. And that's going to give me a really good way of pushing fluid out of those interstitial spaces. And then also you could add on something like furosemide or Lasix to diurese them if they have pulmonary edema. But BiPAP is superior, I think, for pulmonary edema than CPAP. Okay, anyway. We come back, person's hypotensive, we fix that. We give them phenylephrine or vasopressin because those aren't going to cause they're not going to stimulate beta receptors, so they're not going to increase your heart rate, right? Which is nice. The other thing is if they're hypovolemic, not as common as you would think in an ICU. So if it's hypovolemic, you can give them a bolus. I prefer LR over normal saline, but hypovolemic, sure, give them a bolus and see what happens with that heart rate. If they're hypervolemic, which is more common, because whenever someone's in the ICU, they've gone through the ED, and through the ED, they've probably gotten about a liter or two of fluids. So by the time they're in the ICU, they've probably gotten about 2-3 liters of fluids. It's probably honestly not common that they're hypovolemic. It's likely that over a couple days, they're more hypervolemic than anything. So I would go ahead and give them more likely furosemide as a stress test. Okay, and again, if they're septic, if they are in some type of cardiogenic shock, if they have a PE, here's where I really want you guys to be thinking about this, because this is something I've made the mistake way too many times. A person's heart rate's like 120, 130, they're septic. And there's concern, oh man, their heart rate's getting up 120, it's 130. Should we give them some medications to lower their heart rate and target a heart rate less than 110? I've done that, and I've given them medications that we'll talk about later, like metoprolol or diltiazem. And when I do that, guess what happens? I drop their blood pressure, and they get even worse. And the reason why is when you give something like metoprolol or diltiazem or something like that to lower their heart rate, it can also drop their blood pressure. But here's the issue. You lower their heart rate, that might be the thing that's driving their cardiac output right now. So you lower their heart rate too much, you lower their cardiac output, and you cause them to become more hemodynamically unstable. So I would say to take that into consideration, please, when a patient is having these episodes of hypotension and their heart rate is going to be a little bit faster than you like, don't aim for a low heart rate, because if you lower their heart rate too much, that could lower their blood pressure and put them in a hypotensive state. Okay? So, airway, think about high flow nasal cannula, BiPAP. Think if they're hypoxemic, hypercapnic, consider ABG versus VBG. So DB said, what does LR bolus mean? Sorry, I apologize. I use a lot of kind of abbreviations. I apologize. I'll try to do better with that, guys. LR is a lactated ringers. It's more of a balanced crystalloid. So the concentration of sodium and chloride are a lot lower in LR in comparison to 0.9% normal saline. And I like this because it prevents a lot of hyperchloremia, which can actually cause a lot of acute kidney injury. So I prefer LR bolus because it's a more balanced crystalloid. Closer to our actual plasma than a normal saline is. Okay, so with that being said, I don't know what the heck happened here. Okay, here we go. I'll go through airway. Are they hypoxemic? Optiflow. Are they having CO2 retention and our pulmonary edema? BiPAP. Is there any medication that could be triggering them to have a high heart rate? Get rid of them. Is their blood pressure low? Give them BP in the form of a neo, phenylephrine, or vasopressin. If they're hypovolemic, give them fluids. If they're fluid overloaded, give them Lasix. Don't drop their heart rate too much, because you might drop their blood pressure, because that's their primary drive for their actual blood pressure. Then, like I told you, get that BMP. Aim for a potassium, particularly the literature says greater than 4. Aim for a magnesium greater than 2. And we'll talk about a particular thing I like to use called a magnesium drip protocol. Then again, treat their pain. Are they in pain? Give them Tylenol. If that doesn't work, you can always give them a little bit of fentanyl and to see if that helps out. Are they very anxious? I am not a big fan of I'm not a big fan of benzos in the ICU. It can cause a lot of delirium. How can potassium increase in the blood? Sorry, Omar, I don't know what you mean, buddy. So we want to get the potassium up a little bit, so we give them potassium if their potassium was low. So if their potassium was like, let's say 3.0, it could be driving their AFib. It's possible, but I like to push a potassium greater than 4 and a magnesium greater than 2. So if a person is anxious, I'm not a big fan of giving benzodiazepines, especially in the ICU. It can cause a lot of ICU delirium, paradoxical kind of agitation. I will try some, but I try not to give too much of it. What I prefer to do first is I like to put someone on something that's called dexmedetomidine. And if your ICU doesn't have this or the hospital doesn't have this, it's unfortunate because it's a great drug. This actually is a great drug because it's a sympatholytic. So it actually can lower your heart rate inadvertently, and it can help with anxiolysis. So it helps with anxiolysis, lowers your heart rate, and actually can just watch the blood pressure. And sometimes it can actually drop the blood pressure a little bit. But I prefer to give someone like dexmedetomidine because it's not likely going to be one of those that's going to be kind of really altering someone's exam, altering their actual delirium, and causing significant problems for them. So I'm a big fan of potentially trying something like dexmedetomidine for their anxiolysis. And if that doesn't work, then I would consider something like an atypical antipsychotic like olanzapine or something like lorazepam for anxiety. So that's something else I would try too. So I give them like Tylenol first. If that really isn't working, I try to add on something like fentanyl. Usually in my ICU, a lot of the patients have bleed, so it's unlikely that I can give them. In an ICU, you really shouldn't be giving someone something like an NSAID because of the effect that it can have on the kidneys and the bleeding risk. So unlikely that they'll be getting NSAIDs in an ICU. So opioids, usually very low doses of a PRN bolus like that for breakthrough pain is considered. Dexmedetomidine for anxiolysis and lowers their heart rate. But again, if that isn't working or they're still super anxious, I consider something like a benzodiazepine or an atypical antipsychotic. Okay. All right. So these are the things that I try first. Now, once that happens, so let me see. Someone's saying some stuff here. I'm just trying to keep an eye and read through you guys' stuff here. Apologize. Okay. Rate versus rhythm control. So here's my question for you guys. When would we determine a rate control versus a rhythm control method? So if I'm going to try to rate control somebody versus if I rhythm control them in the hospital, why would I determine to do a rate control over rhythm control? So if I have a patient who is in chronic AFib, it's likely that they're going to benefit from rhythm control first off. So I don't even bother. Usually in someone who's chronic AFib, it's not going to benefit them to go through the rhythm control process. If they're a new onset AFibber and they've been in new onset AFib for greater than 48 hours, their electrical remodeling process has already probably started to go through that whole process. And me rhythm controlling them is actually kind of not a good thing, because if I convert them into normal sinus after they've been in a new onset AFib for more than 48 hours, they've had some time to develop some clots in that left atrium. And I would say, I probably shouldn't rhythm control this dude, because if he goes into normal sinus, he's going to get that good atrial kick now and potentially embolize to his brain or embolize to a kidney or embolize to a spleen or the GI tract. So those are the situations where I would pick a rate control method over a rhythm control method, is if someone has a new onset AFib for more than 48 hours or undetermined, and I don't have a clear-cut idea of when, or they're chronic AFibber. I just don't even try to do that because of the risk of strokes. Rhythm control I would prefer in someone who is an AFibber and they're hemodynamically unstable, like we talked about. So they have WPW with AFib, or they have AFib with their heart rate popping and sustaining above 150 with those structural heart problems that's causing their blood pressure to drop because of the loss of the atrial kick. Okay? And the last one that I would consider is if they have a new onset AFib, it happened in front of me and I saw it, I witnessed it. There is good documentation that their new onset AFib popped in less than 48 hours. I would try to push a person back into normal sinus rhythm, because then they don't have a lot of time to go through the electrical remodeling. They don't have a lot of time to be able to quickly have an issue here, such as having time to develop clots within that left atrium. Okay, so if you convert them quickly, it actually might be more beneficial to them to be in normal sinus rhythm. So that's something I would consider. Okay, and so that kind of talks about what I said here, is that AFib with hemodynamic instability, dang it, a new onset AFib, less than 48 hours, because the longer they're in it, it's harder to switch them over. Less likely to develop a clot because they haven't been in AFib for as long. It'll improve their hemodynamics because now they're not going through that less effective atrial contraction, and they'll gain their atrial kickback. So that's something I will consider. And the last one here is atrial flutter. Atrial flutter sucks. It's honestly, I've tried rate controlling these, and they don't frickin' budge. So oftentimes, if someone's in atrial flutter and they're just not, converting back into normal sinus, I will consider kind of rhythm controlling somebody in atrial flutter. Okay. So let me just quickly read here. European guidelines prefer rate over rhythm. Yeah, I think it's a great one. I think rate control sometimes is great over rhythm control. It just depends. I think it kind of depends upon the scenario. So some of this actual literature is from the European guidelines from the UK, especially on anticoagulation. They're kind of the only ones that had a good study on anticoagulation. But anyway, these are the the scenarios in which I would say rate control in a critically ill patient would be superior to rhythm control. And these are the ones I would say that literature shows that rhythm control would be more superior to rate control. Okay. So I hope that helped and kind of gave some explanation, because sometimes we think about these things in school and we're like, oh, I don't know which one to do, rate or rhythm. Rate would be better if they're chronic or NOF greater than 48 hours. Rhythm control would be superior if they're NOF less than 48 hours, if they have AFib that's hemodynamically unstable, or atrial flutter, because those suckers just don't budge with rate control. Alrighty. All right, so rhythm control, baby. How do we rhythm control somebody? So whenever we do rhythm control, one of the things to think about here is I like to try to rhythm control patients that with two particular medications. There was one study that was done that actually looked at magnesium, which I don't know, I thought was kind of interesting, because magnesium isn't a bad thing. It's pretty good stuff. It doesn't really cause a ton of problems. So it's one of those things that, like, you can't go wrong giving somebody magnesium. So I looked at it, and it was actually really interesting, and it was a pretty modest reduction in pretty good at converting people into normal sinus rhythm, and also if it didn't work, it also rate controlled people. So that was kind of the cool thing that I thought was interesting here. So whenever somebody comes in and they have a new onset AFib, less than 48 hours, they have an atrial fibrillation with a hemodynamic instability, and I'm not going to shock them. I'm going to try chemical cardioversion, or they have atrial flutter. This would be something I'd try. So I'd load them up with magnesium. Okay, I give them like 4 grams of mag. After you give them that, you'll start them on a mag infusion at 1 gram per hour, and then you're going to check a magnesium level every 6 hours. And the goal is to get that range of magnesium between 3.6 to 4.9, somewhere around there, at least less than 5. You don't want to get it too higher than 5, because if it gets higher than 5, some of the issues that you start to develop is you can start actually pushing them into the bradycardic range. But here's something that I actually get concerned about, is they start getting weak, they start getting hyporeflexic, they start getting somnolent. And so this is something that I would actually say, okay, we should probably stop the infusion and say, hold off on this a little bit. So one of the things I will look for is I'll try magnesium, I'll bolus them, start them on a drip, and keep an eye on their magnesium for about every 6 hours for 24 hours, and try to get them in this nice range and see if it converts them. If it doesn't convert them, the nice thing about this is that it probably will rate control them. So that's a pretty cool thing. One thing I would say is don't run that mag too long. Sometimes it can cause some problems, especially, here's my thing where I would say be careful with even trying this, is if someone has renal failure. Like if they have chronic kidney disease and their GFR is less than 30, or they're anuric, or they have a severe acute kidney injury and they are just not making urine, I would probably not give them any magnesium infusion whatsoever, and instead give them boluses. And probably one bolus, check their level, and then again keep checking their levels to make sure that it doesn't accumulate. Because the whole goal of this is to up their mag, to cause MAG to block those calcium channels around the actual cardiac myocytes and reduce calcium entry into those myocardial cells to reduce the arrhythmias. So that's something I would be very careful with the magnesium. Just be careful if they have kidney failure, and keep an eye on that MAG level, and keep an eye on any bradycardia. Weakness and somnolence is the big thing here. But this has actually been pretty effective and something I like to do. I like to give it the old college try with this one. The next one here. So someone said, Kyle, it is last thing you care about is diarrhea. Yeah, diarrhea can definitely be a potential symptom here. Magnesium is a cardiosuppressant. In a way, I guess you could say that. Yeah, it's pretty good at rhythm control. And if it doesn't work, it rate controls. And there has been, I think there was like a couple studies that looked at magnesium on the actual effect on blood pressure. And it can potentially cause a vasodilatory type of action, which could drop the blood pressure a couple points, but nothing significant. But it's great at really kind of like just helping out with those cardiac membranes. I think that's one of the great things about this drug. But all right, the other one I like to try is amiodarone. Amiodarone is pretty great. And so amiodarone will actually, what I'll do is I'll load them with 150. I'll give them a bolus of 150 milligrams of amiodarone and start the infusion at 0.5 or 1 milligrams per minute. And I'll watch them and see if it drops their heart rate or see if it converts them, okay? If it doesn't convert them and they've been on the 1 milligram per minute and they only responded to 150 milligram bolus and they're still not really kind of converting and their heart rate's not budging, I'll give them another bolus. So I'll give them another 150 and I'll look. And if it didn't really change at all, they haven't really converted, I'll give them another 150 bolus. So I'll re-bolus them. I really try to stay away from going more than like 450 to like 600 milligrams. I kind of stay around that. I'm a little bit more of a wussy. I probably would go to like the 450 milligrams and I probably stop bolus. Maybe I would consider though, and please take this into consideration, is that when you have a patient who you're putting on amiodarone, you have to potentially consider, am I going to keep them on this amiodarone long term? And the reason why is I would reconsider that is that amiodarone has a lot of problems. Obviously, it can cause some issues with the thyroid gland, can cause some thyroid issues, and it also can cause the amiodarone lung, so some fibrosis of the lung. So I would probably try to stay away from chronic long-term use of amiodarone. I would stabilize them on any amiodarone, get them converted, keep their rate down. And then afterwards, I would keep them on kind of an oral, for the love of crap. I would keep them on amiodarone for about 24 hours, and then I would go ahead and convert them over to like a beta blocker or a calcium channel blocker long term. But I would try to stay away from keeping someone on a amiodarone medication orally long term, just because of the negative side effects it can have. But this is something I really enjoyed doing. I tried the magnesium, and if the magnesium doesn't work, I have the amiodarone. And guess what? Having the magnesium and doing this, if it doesn't work, I add on the amiodarone. Usually the amiodarone with the magnesium, the cardiac membranes are super stabilized, and this amiodarone really works so well. And so that's one of the things I've noticed, is that most people will convert when we give them magnesium and then afterwards give them amiodarone. The nice thing about this is that no matter what, if a person is getting magnesium and amiodarone, they don't convert, this also rate controls them. So that's kind of like, oh, this didn't work. You know, shoot for the moon. You know, it didn't work. Okay, well, at least you hit the stars and you're getting some kind of benefit from it. The other thing I think is really cool is they did a study, which is after patients were on amiodarone and magnesium, and you actually cardioverted them, you electricity-wise, you gave them direct current cardioversion, they actually converted relatively easy. So that was something that was pretty interesting. So putting someone on putting them on amiodarone and magnesium infusion, and then cardioverting them, they had a higher success of staying actually converted into normal sinus rhythm and less likely to reconvert, which was pretty interesting. But there was actually lower rates of reversion. There was lower rates of cardioversion with patients who were on beta blockers. So a pretty cool thing. So again, I like to start with these. If they don't work, at least the benefit from them is that I rate controlled them. And if they needed to be cardioverted, they have a higher success rate with cardioversion. Okay. Okay, here we go. So rate control agents. This is probably where more likely you will probably deal with, especially outpatient. These are the more likely agents that you're going to manage with these patients. But I will consider, again, rhythm control for those specifics. So we talked about who we rhythm control, who we rate control. I'll try that rhythm control pattern right there. Magnesium, amiodarone, direct current cardioversion for those patients who are new onset AFib less than 48 hours, AFib with hemodynamic instability, or atrial flutter. If they are chronic AFib or no onset AFib for more than 48 hours, I do not even try that. I go straight for the rate control. Okay? So, rate control agents that I would like to try. It depends. And this is where it's a little tricky, and sometimes it's really kind of one of those that you have to do it based upon what the patient looks like. And so let's say I had a patient, right? So, he is, well, actually, before we do that, here's what I was telling you about before, guys. So there was a thing called the RACE 2 trial, but this was particularly for outpatients. And it suggested that we target a heart rate less than 110 in patients with atrial fibrillation. However, here's the issue. With patients who are critically ill, there's not a lot of literature to show what should be the target heart rate. Should we aim for less than 110? Because sometimes that's not realistic and it can cause harm. Why? Because if we drop their heart rate and they have this critical illness that is causing them their heart rate to be increase as a compensatory mechanism to increase their blood pressure, we take that away. We cause them to become more hemodynamically unstable. So one of the things I think that's interesting is there's not a lot of literature to say, there actually really isn't any, that suggests what should be the targeted heart rate in a patient who with atrial fibrillation who's inpatient critically ill. And so what I have noticed, and I've read throughout multiple different kinds of intensivists, like blogs and different types of literature, is that they say aiming for a heart rate that's like less than 130 is kind of appropriate, because it wouldn't actually kind of alter, if they're around 130, it doesn't significantly alter their diastolic filling process, and it actually helps them to maintain a good cardiac output. So that's something I aim for. This is my practice, is I have a 130, just to keep that in mind. Okay, so this is something I think about. I consider less than 130 to be my goal, and I also really look at their hemodynamics. If they're hypotensive, I will probably consider these drugs: digoxin, amiodarone, and magnesium. Okay, and you're like, wait, Zach, I know digoxin is good for rate control, but I thought amiodarone and magnesium were the rhythm control agents. They are. But if I have a patient who's a chronic AFibber, right, and they're unlikely to convert, I have a person who had new onset AFib for more than 48 hours, these drugs are actually pretty good because they're going to rate control. Okay, they're unlikely to probably convert somebody out of atrial fibrillation into normal sinus rhythm. So these are the ones that I'll go with. Okay, so if they're hypotensive, I will probably consider something like amiodarone, magnesium, and if these don't work, I go with digoxin. Okay, so digoxin is a pretty good drug. When we do digoxin, one of the benefits behind digoxin is that it actually increases your inotropic activity, right? It's not significant, but it does it a little bit. And it also doesn't drop your heart rate a ton. So digoxin may drop your heart rate down like, 10, 15 beats per minute if that's what you're aiming for with this drug. So if I have a person who is hypotensive and they're in AFib and they're popping above 130, 150 and they're sustaining that, I'll try magnesium, I'll try amiodarone, and then if that doesn't work, I do digoxin. Okay, so the nice thing about digoxin is give me some increase in inotropic activity, and it'll drop the heart rate without dropping it significantly. So usually I'll talk about the candidates best for this one. If they're like hypertensive or kind of like normal tensive, so let's say normal tensive to hypertensive, I will consider something like, so this one's interesting. So it's not technically a rate control agent, but I will use it. I'll sneak it in there a little bit sometimes because I think it gives people some good anxiolysis, but it also lowers their heart rate a little bit. I'll try dexmedetomidine. It's a pretty good agent. It doesn't actually sedate them enough that it doesn't remove their respiratory drive. So it actually gives them to anxiolysis and will drop their heart rate a little bit. So if they're kind of normal tensive to hypertensive, I will try something like dexmedetomidine. I think it's a great agent at trying to give them a little chilled out. But generally the go-tos, these are the go-tos here: diltiazem or metoprolol. So here's kind of, again, to recap it. What do we target as our heart rate? Some will say less than 110. Really, that might not be a good thing in a patient who is truly critically ill. That might be their compensatory mechanism. Aim for maybe a little bit more like liberalized, less than 130. Which agents do I use? If they're hypotensive, I probably would stay away from diltiazem or metoprolol. But you can still give these even if they're hypotensive. You just might have to give something to kind of like counteract that hypotension. And so that's something else that we'll talk about. Sometimes people do not want to try amiodarone and magnesium, and that's completely fine. These are just a little bit more hemodynamically kind of like stable is what I would say. So these are the preferred ones if a person's a little bit more hemodynamically tenuous. these ones. But sometimes people will not use these, and they will rather give something like diltiazem or metoprolol and support their blood pressure with something like a fluid or a pressor, which is completely fine. But dang it, this dang thing. But again, it's something I would consider, maybe considering these two first, trying digoxin if that doesn't work, and if they're normal tensive to hypertensive, diltiazem or metoprolol. And if you need a little bit of help and they're anxious, dexmedetomidine is a great drug. Okay, I hope that answered some questions. So let me see here. Ali said digoxin provided potassium levels monitored. Yeah, so the nice thing about digoxin is, especially in ICU, I have a lot of just crazy respect for those cardiologists who will give patients like a bottle of digoxin and say, "God in the world." I am kind of like, I have the benefit of being able to check digoxin levels in the ICU or in the hospital. So that's a little bit easier for me. It's easier for me to be able to give digoxin and load someone with digoxin and give them dosages, because I can actually kind of check their dig levels relatively easily in the hospital. So that's one of the benefits of this kind of medication in the hospital. But yeah. So Brian said aim for a heart rate less than 130 and greater than what? Oh, well, I mean, if you're aiming for the lower end, I would try not to drop them I prefer less than, I don't want to go, lower than 50 beats per minute. So preferably, I wouldn't want to drop them too hard. If you drop someone's heart rate down pretty significantly, you could potentially drop their cardiac output. So, aiming for heart rate, I like less than 130, but I don't want to push them down to the point of where they're 50, 60, 40, 30. So if you want to be a little bit more safe, I'd say heart rate less than 130 and a heart rate at least greater than 50 to 60. I wouldn't want to go lower than that. Great question. All right, candidates for digoxin. I think this is great for patients who are chronic AFibers, right? Because you're rate controlling them. If you're deciding to rate control them, they're likely a chronic AFibber. And then the other thing is they have a HFrEF, right? A heart failure with a reduced ejection fraction, right? So maybe less than 50%. So they're pushing 25, 30%, 40%, whatever. They have a HFrEF and they have a reduced ejection fraction. This will give them some inotropic kicks. That's another benefit to it. The other thing is I'll only do this for patients if they're tacking away super high. I don't find much benefit for this one for a rate control agent. So I will go for a mild to moderate tachycardia for these patients. If they're popping around 140, 150, this might drop them down to 130. So it's a nice little benefit one, and I might add something else on to give them a little bit more of a kick as well. So it's good for mild to moderate tachycardia, 140, 150. And I also look at the renal function. Now, regardless if they have poor renal function or they have good renal function, I can get around that because I can check their dig levels. And if at any point in time their dig levels become too high, I can stop it, give them something like Digibind, and I can also keep an eye on their potassium levels daily. So, and that's one of the things that makes it a little bit easier in a hospital setting, whereas outpatient, it's a little bit more difficult to manage. So when I load somebody, if they have a normal renal function, you can see here, you can give them 8-12 mics per kg, ideal body weight. And then if they're renal insufficient, I go 6 to 10 mics. I prefer to aim for the lower end. So for normal, I go 8, and for renal insufficient, I go 6. And then once I do that, I give 50% of that as a load, and then I'll give 25% in 6 hours, and then another 25% in 6 hours. And then once we've gotten them loaded up with those 3 doses, I'll put them on a maintenance dosage range based upon their age and renal function. And so that's right here. If they're less than 70 with a normal renal function, they'll get 250 mics. Greater than 70, renal dysfunction, 125. And greater than 70 and renal dysfunction, they'll get 62.5 mics a day. And again, the nice thing is I can check my dig levels pretty much daily if I wanted to, at least 8 hours after I gave my last dose. And that can give me my dig level to make sure that I'm not in a toxic range and I'm not in a subtherapeutic range. And that therapeutic range I like to aim for is particularly in the ICU is maybe 1 to 2. You might want a little bit higher than normal in these ICU patients because of their critical illness. But therapeutics and outpatients particularly tend to be around 0.5 to 1. In ICU patients, you might want it a little bit higher to get that extra benefit from it. So 1 to 2 may be the preferred in a patient who's in the ICU. Okay, so again, hypotensive patients, chronic AFibers, you're choosing to rate control them. You can try magnesium amiodarone. Some people don't like to do that, so they'll try DIG. Okay. All right. So next one, beta blockers. These are probably one of my favorite ones. Most of the patients I get in my ICU, they're around the normal tensive to hypertensive range. It's not super. Sometimes I'll get some patients who are hypotensive, and my preference sometimes is I will try the magnesium and amiodarone. But if that doesn't work, sometimes what else will be something else to consider is I'll kind of support their blood pressure with something like phenylephrine, and then give them something like metoprolol as well to be able to get that rate control. And then on top of that, the phenylephrine to support their blood pressure. So sometimes you can get around that hypotensive state by giving them something like metoprolol to lower their heart rate, and then phenylephrine to support their hemodynamics. So again, those are things that we can consider. But nonetheless, if I'm trying to manage a patient rate-wise and we want to do something like metoprolol, I think that this is the beta blocker of choice. I have never used esmolol once, and I hate it. It's just a pain in the crack. I don't like this drug, but sometimes it's cheaper. It's a little bit preferred in certain situations. But I'm not a big fan of esmolol. I prefer metoprolol. Metoprolol is actually the beta blocker of choice most of the times. And this is actually, if you go back to that original statement we said, in patients who are in the ICU, they have that high catecholaminergic surge, they tend to be a little bit better in responding to beta blockers, okay, because of that sympathomimetic effect. So I like to give this drug preferably. Now, again, keep an eye on their blood pressure. If it's low, again, you can support it with a little bit of neo. And then again, aim for a heart rate. I prefer less than 130. Okay. So when I load them, let's say I have a person who's popping into AFib and they're around like 150 and they're sustaining. I will try 5 milligrams first. Okay. I'll try 5 milligrams IV and I'll see what happens. If that doesn't work and it doesn't get them less than 130, then I'll give them another 5 milligrams and about 5 minutes later. See if that gets them less than 130. If that doesn't work, I'll give them another 5 milligrams and see if that does it. Generally, what I'm looking for is I'm looking for their response. I'm looking to see how do they respond to this actual metoprolol. And once I get an idea of what their response was, so let's say I gave 5 milligrams, they didn't respond. I gave them 10 milligrams, they didn't respond. I gave them 15 milligrams IV and they did actually drop their heart rate less than 130, then I know what oral regimen I'm going to stick them on, because there's a nice conversion of 1 for the IV to PO ratio. It's a 1 to 2.5 ratio. So if a person responds well to 15 milligrams of IV metoprolol, they'll be best suited for a 37.5 milligrams of metoprolol every 6 hours scheduled. And so that's kind of how I will look to try this. And that depends if they can have oral access. So sometimes if they can't swallow because they had a stroke, they might have something like an NG tube or a DOB-HOB where we'll feed that medication through. If they don't and we can't get any oral access for them, then we might just have to put them on an IV schedule that they were responding to. If they're responding to 15 milligrams IV, I might have to put them on that every 6 hours, okay, until we can get oral access and then put them on that regimen. So this is what I kind of like here. This is kind of my preferred practice. This is what we usually do is metoprolol for our patients. And if we have to support their hemodynamics with a little bit of neo, we will. Okay. But there is some pretty good evidence, again, going back to the hypotensive states for magnesium and amiodarone. And I've seen some benefit from that as well. Esmolol, again, I'm not a big fan of it, but here you go. I wrote these down, looked at the literature for this one. You can load them up at 0.5, start the drip at 0.05. And if they're not in the parameter, you can give them another load of 0.5 mg per kg and then increase the drip up 0.05 mics every 30 minutes until you get to a max of 0.2. Once you do that, you try to get them within that range. Again, I'm not a big fan of this drug. It's a lot of pain to titrate, but something else to consider. All right. I hate this drug too. I'm not a big fan of it. Sometimes I'll try it, but I pretty much never use the drips for diltiazem. I will try boluses, but I don't know. Sometimes they're just not really effective, and the literature doesn't actually suggest this to be superior. There was a paper that showed that diltiazem was superior in patients within the emergency department with atrial fibrillation and compared to beta blockers, but that was boluses. That didn't compare beta blockers to diltiazem with an infusion. So when you're comparing diltiazem infusions versus metoprolol boluses, there is actually no evidence to suggest that diltiazem is superior. Only boluses of diltiazem in the ED in comparison to metoprolol was superior. So I would probably go ahead and say try to stay away from diltiazem infusions because of the accumulation factors, and they just can become very difficult because they don't get titrated sometimes super properly. So what I like to do is I will try this. I'll give let's say I go through the metoprolols, I give 5, I give 10, I give 15. They don't respond to that. I might actually give a bolus of cardizem or diltiazem. That's another name for diltiazem. I will give them maybe a 0.25 milligrams per kilogram IV bolus, with the max being around 25. If I give them that bolus of cardizem and they don't actually drop their heart rate down to less than 130, which is my goal, I'll try it again in 15 minutes. And if they do respond, you can consider putting them on an infusion, but I try to potentially avoid doing this, and I will switch them right into for the love of crap, I will switch them over to a PO diltiazem. And sometimes you can determine the calculation, like the conversion. Again, I've never done a diltiazem infusion because I don't think that there's a reason to. But here, if you were to put them on an infusion, you can do 2.5 to 15 milligrams per hour. But usually I like to transition them to oral. If they respond to a bolus, I'll put them on an oral. And then right away, I'll kind of just go ahead and go with that. But if you put them on an infusion, you can actually use the infusion that they were on for a significant amount of time and determine what oral dosage range they could be on if you put them on the extended release. Usually what I'll do is I'll give them a bolus of cardizem, see what they respond to. And then if they do that, I'll use the conversion to determine their oral range as well. But you can use the infusion and utilize this calculation. If they were on 3 milligrams per hour, you plug that in there and you'll get that they're at 120 milligrams of cardizem, PO extended release per day. So this is something that you can definitely give a shot to. But I usually will do metoprolol first, and if it fails all of those bolus responses and even the oral, I may consider something like diltiazem. But one of the things please, for the love of goodness, don't do this. It's like the kiss of death is if you put someone on a beta blocker and then later on you add a calcium channel blocker. Oh, for the love of goodness, please do not do this. So that's one thing I will stay away from, is putting them on a beta blocker and a calcium channel blocker. Pick one of the two. Do not do both. You can do diltiazem and digoxin. You can do beta blockers and digoxin, but please do not do diltiazem and metoprolol. It's going to be problematic, okay? So these are the things that I'll consider. I will do one or the other. Beta blockers, metoprolol, or calcium channel blockers, diltiazem. But the evidence supports metoprolol in critically ill patients over diltiazem. Okay? The last thing here, and this is something that I wish I could find, we have good evidence for outpatients as to when we should anticoagulate them. We utilize the CHA2DS2-VASc score, and we determine their bleeding risk with the has bled score. But in patients who are critically ill, there is no actual validated, literature out there to suggest who we anticoagulate, particularly these new onset AFibers. That's the ones that are tough to determine. There is not a lot of literature out there to suggest the new onset AFib patients who are critically ill, do we anticoagulate them if they've been in AFib for more than 48 hours? And there was one study, a UK study, that actually looked at it, and they found that like 67% of practitioners avoided giving routine anticoagulation in new onset AFibers. And they found that there was really just no, change in like stroke. So what they did find is that patients who were on anticoagulation, who had new onset AFib, more critically ill, had higher bleeding rates, and there was actually no reduction in stroke incidence. And so with that being said, I think some of the literature, especially from the UK studies, potentially suggest that, one should potentially avoid anticoagulation in patients who are critically ill, just because there's not a lot of evidence out there. Now, a patient who has a chronic AFib, if they're a chronic AFib, those patients, we can utilize those outpatient scoring system like the CHA2DS2-VASc and the has bled and determine their actual need for being on anticoagulation. That we can use that for, but the CHA2DS2-VASc score and has bled doesn't actually truly apply to patients who are critically ill. It hasn't been validated in that sense. So that's one thing I would consider. If they're a chronic AFibber, you can most likely just put them back on whatever anticoagulation they were taking prior, before they came into the hospital for their critical illness. Once they've been a little bit more stabilized and there's no concerns for bleeding, you can always put them back on whatever their previous anticoagulation was. But for patients who are new onset AFib, who are critically ill, it might actually be more beneficial to avoid anticoagulation in those patients, just because potentially there's research that shows lower bleeding risk and no true reduction in strokes. So that's something to think about. But All right, engineer. It's a cute little little thing here that Rob put in here. He's such a nerd, but yeah, it was a pretty interesting thing. I enjoyed doing this atrial fibrillation kind of dig into the literature because it helps me be a better practitioner. It helps me try to understand how to truly like diagnose and think through these patients clinically and how to manage them. Because we don't want to just take things from the textbook and try it. We want to take things from the literature, take things in a very pragmatic and systematic way and have a good idea of how to approach treating these patients. And so I really hope that this helped to give you guys a pretty good idea of how to approach these patients and how to, utilize the literature in your defense. So Robic said Rob is such an MVP for making that meme. I know, it's so cute. It's so nerdy, but it's so cute. So yeah, I really hope it helped. I hope that you guys liked it. If there is any questions, let me know. I'll hang around for a couple minutes and then we can try to go through any things. But if you guys did like this, let me know. If you don't like it, we don't have to do this anymore. I like this new style case where we know the condition and learn how to diagnose and manage. Yes. Oh, wow. So people did really like it. Okay, good. I was a little nervous because I felt like, it might have been a little bit more lecture-y, but my goal was to try to make it more like clinically relevant. We're going to be all practitioners hopefully one day, right? Whether it's a PA, whether it's a doc, whether it's an MP, whether it's a nurse. And if we have better understandings and reasons as to why patients develop AFib, new onsets, critical illnesses that can potentially exacerbate it, how to think about their treatment and what truly the evidence suggests, I think it makes us better practitioners. So I hope that you guys did like it, and we'll keep going through these things and keep trying to, really understand it. Maybe the next one we'll tackle, since we did ischemic heart disease for YouTube, maybe we'll tackle myocardial infarction and how to better diagnose and manage that as well. So, but please, you guys call me out on anything. I do the best I can to find whatever literature I can out there on this stuff. If there's something that I missed and there's any literature or any kind of evidence-based stuff that you find, please throw that in the description box or in the comments or email us. Don't put anything down in the comments that is kind of like anecdotal. Try to put down, if you have a particular reason as to why you think something should be potentially looked into or is not correct in this kind of case study, please put it down in the comment box, but please put some actual evidence-based literature support behind that, just so I can go through, look at it, and see what could be coming from that. Okay, so please do that. But I hope you guys like that. Where can I get your notes on our topic? Oh yeah, you can go onto our website, ninjanerd.org. And we have all of our notes. We have our awesome illustrations that our medical illustrators and note makers actually develop really, really great. And so our team worked really, really hard. Rob worked really, really hard to develop a great website for you guys. And so go check that out. Okay, best if you join the Discord. All right, engineers. Well, I'm glad you liked it. I'm really am. I hope that we can meet up next week and we can have some fun again, talk about some more stuff. I just always enjoy kind of talking with you guys, and I'm so thankful that you guys really enjoyed it. Hopefully we can keep doing these and keep learning more and more and more and helping out people around the world to be better clinicians. I know that when I went into the medical field, I felt so lost and so stressed and just overwhelmed with the amount of information that I needed to know, and I still feel that every single time. And so one of my goals is to help practitioners, help nurses, help PAs, help docs become a little bit more comfortable in what they see and how to evidence-based wise, because that's how we should practice off evidence, is to be better practitioners, to think pragmatically, critically, not irrationally make decisions, and just be good practitioners for our patients. So I hope that we can continue to keep on this journey together, Ninja Nerds. All right, Ninja Nerds, I love you. I thank you. And as always, Ninja Nerds, until next time.